afternoon, everyone. While you're finishing getting seated, I want to do some housekeeping details. Hi, my name is Lucia. Oh, sorry, I'm out of the zone of the camera at Riley. Hi, everybody on the network. I'm Lucia Voschel. I'm the nurse ethicist here at Indiana University Health, affiliated with the Fairbanks Center in the Department of Nursing. So some housekeeping stuff. First of all, thank you very much for coming. I know some of you were riding the single people mover that was in service. So thank you for that. The lecture is being recorded and broadcast. Thank you to those of you who are joining us from the Rock Auditorium, IU Health Saxony, IU Health Ball Memorial, and IU Health North. Now, I tell people all the time that my cell phone up until recently was so old that it didn't fold and it had an antenna. I have children who would rather go without a cell phone than borrow mine, and I say that as a happy way of saying, pull out your cell phone, take a look at it. Can you fold it? Is it flat? Please, please, please put it on silent. Please put pagers on silent. If you're paged or called and you need to speak to someone, please quietly stand up and make your way to an exit and have a conversation outside the room. It's very distracting for audience members when you forget to do that. And some of us have perfected the art of glaring should you forget. So I have the distinct privilege of introducing Dr. Elaine Cox today. Dr. Cox and I met early on in my tenure here at IU Health, and she was one of the bold and courageous volunteers who helped us with our pediatric ethics initiative at Riley Hospital, so I'm very grateful for that. She's been a terrific resource. She is a graduate of Indiana University School of Medicine and has been a faculty member of the section of pediatric infectious diseases at Riley for 18 years. Her interests include pediatric HIV/AIDS and infection prevention, and these interests are coupled with the time that she spent in the Pediatric Ethics Consultation Service led to her involvement with the Indiana Legislature regarding laws for HIV testing in pregnant women and eventually in HIV testing in general in our state. So she's been very active in a very important healthcare initiative. Continued advocacy for those infected with and affected by HIV remains her passion. 2 community awards are evidence of this passion. In 2011, she was awarded the Indiana Perinatal Network Spirit of Service Award in the category of advocacy, and in 2012, she received the Courage to Live Award from the Indiana Minority AIDS Coalition as the Compassionate Caregiver of the Year. Please join me in welcoming Elaine Cox.
Thank you. Thank you very much, Alicia. So I have a lot to say, so I'm just going to start talking, and I can talk really fast, so I apologize for that in advance. So the objectives of today are to kind of review the medical evidence that supports our position on routine HIV testing in pregnancy, and then to discuss some of the ethical concerns that have grown out of that, and to illustrate sort of the discord that can happen between those two things by some actual cases that we have encountered. I don't have any financial disclosures, but I have a couple of disclaimers. One is that I am a clinical pediatrician, and translated that means I'm very clear where I stand on this medically. My life has been spent treating people who are HIV infected. And so for me, there's a very clear medical stance that I have. So I just want to put that out there from the beginning. The second disclaimer is that I'm breaking my 2 cardinal rules of speaking. I hate to be the least knowledgeable person in the room when I'm speaking, and that is how I feel. While I've spent time with Lucia and time with Dr. Health, I am not an ethicist, but I am a pediatrician who tries to practice ethically. So I'll do the best that I can with that. And secondly, I'm kind of a dragnet, just the facts person, and medical evidence, but it is impossible for me to talk about this particular subject without telling a little bit of my personal journey of how I have, I hope, evolved over time. So I'm not going to read this to you because I know very well what it says. It basically says that we know through medical science that we can take the risk of transmission from mother to baby of HIV during pregnancy, at delivery, and after from about 25 to 30% down to less than 1 to 2%. It is proven scientifically. It has been replicated over and over again. But the most important part of this to me is that this is the only prevention effort to date that has been reliably proven to work. And so I'm a pediatrician. I said that in the disclaimer. The cornerstone of pediatrics has always been prevention, prevention, prevention. We can prevent the spread of HIV in this realm. But the only way we can do that is by intervention. And we don't know when we can intervene if we don't test. And I say that I don't have to read this to you because I wrote this. This was the testimony we used at the Indiana State Legislature. And it sort of crystallizes that medical position I talked about. And I have not strayed from that stance at all, but as I hope you will see, I have widened my view over time. There is a man, Conrad Fisher. Dr. Fisher's written many, many things about HIV testing, and this is one of my favorites that he's written. If HIV were treated as any other infectious disease, and if children could protest for themselves, we would soon cease being so apathetic in our drive to identify and treat the infected as well as protect the uninfected. As physicians, we have an ethical responsibility to prevent any degree of unnecessary illness or death, no matter how small the amount may seem, and to give every human being a chance at a normal, healthy life. I think for most clinicians, this is the position, that we have to prevent at all costs. But that's thinking of it purely from a clinical standpoint. And so we're going to talk about some of those things as we move forward. So just to give you a little bit of HIV, and I was telling Lucia I really had to force myself to keep this part small, right? Because this is my comfort zone. So I could talk to you about this all week, but I won't. I'll spare you. But I'm just flashing these up here to show you that HIV disease is still a significant issue in the United States. We have at least 1.5 million people we know are either living with HIV or living with AIDS. We know there are probably close to 10,000 in Indiana. We know that more than 500,000 people are dead from AIDS. We know that new infections continue. There are 56,000 new HIV infections in the United States every year. And the hardest part to accept about that is by the time we discover them, almost half of those people already are at the stage of AIDS, which means we're finding them very late. We also have a significant issue with viral load in Indiana. Our average viral load in our HIV infected is 4 times the national average. So we have issues still related to HIV. So we have to remember that this is not a disease of the past. It's still very much in the present. Women and children are among our fastest growing groups of new HIV infections, and that makes sense because women are our childbearing population, and so that transfers into babies. More than 95% of pediatric HIV cases are now related to mother-to-baby transmission since we test the blood supply. That's a very good statement, but I will admit that that's for 13 years and younger, which is what we consider true pediatric population. The adolescent population is still a different bandwidth on that scale. About 1/5 of women lack prenatal care. It doesn't mean they don't get any, but most of those don't get full prenatal care. And like I said before, mother-to-baby transmission is high without intervention and treatment, but low with treatment. Since we started doing intervention across the nation, we used to have about 2,000 new infected babies a year. Within 5 years of this intervention, we cut that down to 300 babies a year. And in 2004, which is the last year we have hard data for, there were only 48 babies infected in the United States. So this intervention does cut transmission. The other thing I want to point out is that there's no cure for this disease. So we can treat it and we can manage it, but there isn't any cure. So the best thing is to prevent acquisition of the disease, and that needs to be one of our mainstays as we proceed forward with these efforts. So ACTG 076, this stands for AIDS Clinical Trial Group number 076 study. It's one of those studies that somehow miraculously got by without having a cute name, because most of them do, and people just call it the 076 protocol. It was the landmark study regarding this intervention. It actually was published in the New England Journal of Medicine in 1994. And it talked about, at that time, treatment of the mother with just cytovidine or AZT, doing a C-section, and giving the baby AZT for 6 weeks after birth. This was one of the few studies that's really been stopped early because it became sort of unethical to assign people to the randomized arm of placebo or no therapy because the results were overwhelming. In the first go-round, they went from 25 to 30% down to 8.5%. With better treatment with combination therapy of mothers, it went down to 1 to 2%. We also discovered somehow through this that there are other benefits to testing, including earlier diagnosis and treatment of the mother. Remember I said 40% of people by the time they present have AIDS. The cost of care for end-stage age is for salvage therapy is about 75% more expensive than first-line therapy, as well as survival rates go down the later that you are diagnosed. In addition to that, you can decrease the spread of disease to other people by allowing for behavior modification, safe sex practices, not needle sharing. When we have such a high community viral load, our risk of transmission is higher. And so this gives us an opportunity for education and risk reduction. And also with regard to the baby, we can make better decisions about breastfeeding opportunities and pneumocystis prophylaxis. So what about the financial impact? Well, this is significant, and I don't think in this day and age of medicine we can ever talk about an intervention without knowing how much it costs versus how much it saves. So the CDC did this financial impact analysis, and they looked at if we prevented 656 cases, what it would save us. We would go from spending $105.6 million for cost of care over a lifetime down to the $67.6 million that it cost us to prophylax. Now, I will tell you, right, we've prevented more than 656 cases in a year from the statistics I shared with you. And also, the lifetime costs of prevented patients are probably a lot higher than this. So while this is impressive, it's probably an underestimate of the amount of money that would be saved. When we looked at Indiana and Riley especially, what we know is for 40 patients a decade ago, it cost us about $2 million to take care of them. And that's if they never got sick. That's if they just had meds and they just had their labs and they visited with me 3 or 4 times a year. The meds are thousands of dollars a month. So if they never got sick, it would cost us $2 million to take care of our infecteds. It would cost us less than $40,000 a year to prophylax all babies born in the state of Indiana. Financially, I think there's no question. So what happened after this 076 protocol and these financial impacts are that our big groups started coming out and making very important statements. This is the joint American Academy of Pediatrics and American College of Obstetrics and Gynecology statement. It's interesting to me that it was made in 1998. Remember I said that study ended in 1994. It took 4 years. 4 years from really no question that this was a successful intervention to get this statement. But this is a very important statement. All pregnant women in the United States should be offered routine HIV testing with patient notification as a routine component of prenatal care. So we introduced the word routine really for the first time. Counseling should be a routine component of prenatal care, but not a prerequisite for nor a barrier to perinatal HIV testing. That was a huge statement because we were taking the consent process away. And that really started a firestorm that, to be quite honest, raged for a long time and still smolders today. Other groups followed quickly. The Institutes of Medicine, we all know them from the do no harm, right? that got our safety culture going. They came out and said this needs to be integrated into the standard prenatal battery of tests. And finally, 6 years after the original study ended, the Centers for Disease Control came out and said, you don't need to stop testing because of counseling and consent requirements, and that parental consent does not relieve the physicians. If they withhold that, does not relieve the physicians of their professional and legal responsibility to their patient. And I love the CDC, right? I'm an ID doctor. I spend my life acting on what the CDC tells me. CDC has one fault. They love to tell you that you should do this, and they give you absolutely no direction about how that's going to get done. Happens over and over. In addition to that, they talk about refusal of the parents to give consent, but they don't say when in the process that is. Is that regarding the fetus, or is that after the baby is born? And so this sparked a lot of debate for a very long time. So in the middle of all this, we started our trek here in Indiana, which I'm going to share with you now. It only took us 3 years to get going. We started in 1997, and initially in Indiana, there was absolutely no uniform testing policy. People said, you ought to be teaching people and you ought to be testing, and that was where it went. And we weren't. We weren't testing. We weren't seeing any tests come through. And so in 1997, we went after the original idea, and what we ended up getting after 2 years of very heated debate was what we call an opt-in policy. And an opt-in policy means we sit down, we discuss, we do risk assessment. If your practitioner and the pregnant woman decide that she needs a test, she signs an informed consent. This takes a tremendous amount of time and requires risk assessment. In addition to that, in 1999, what we call the 48-hour caveat was put into place. And so in the first 48 hours of life, if a practitioner for a newborn feels that that baby had any type of exposure and was not tested prenatally, we can test them postnatally without consent, but only in the first 48 hours of life. I think that was sort of a concession to us very righteous, emotional pediatricians that were going through that process. But the reality is that really doesn't help us very much, because the key time for intervention is at delivery. And if you've missed the opportunities at delivery, your chances of prevention go down significantly. Not to zero, but significantly. The other issue I have with this now that I've matured, which I'm not sure I had when it first came out, is you're still diagnosing the mother. This is kind of an end around. The mother is going to get diagnosed off this test from the baby. And so if she has refused testing before, we're still going to diagnose her. And I think that that presents its own set of challenges. The other thing as a physician that I can tell you, and I have been doing this now for 18 years of my life, you can't tell by looking who has anything, let alone HIV. Risk assessment is very difficult to do. Even the patient themselves has a hard time doing risk assessment because they don't know the exposure of every exposure of every exposure. And so we're asking ourselves to do something and assess a risk that is nearly impossible. So what we found from this opt-in policy, no surprise, was that testing did not increase. Why not? Why can't we go to an opt-out policy, which is what we're going to get to eventually and what I'll describe to you, but there was such fighting about it, and why? Well, there's not a lot of public support for this. People do not want to force someone, as they see it, to get any kind of medical test. In addition to that, there were several private agendas, and there was a big fear of generalization to other populations. People were fearful that we would identify mother-baby dyads and not have the resources to treat them. And then how would we protect their confidentiality and privacy? Now, when we started this, I had only been here about 5 years. And I was very young in my career, and I was so certain that we were absolutely right in doing this that I could tick these things off and say, you know, the public doesn't understand. They don't care about the babies. Unless some other population is suddenly going to get pregnant, this will never generalize. And if we don't have the resources, we'll just have to find the resources. Over time, I've matured and know that those things aren't always as easy as I wanted them to be. And so these were major concerns that held things up. Eventually, after 6 years, so around 2004, 2005, we did adopt an opt-out policy. What an opt-out policy means is that the testing is routine with notification. So it's on the standard battery of tests, but I tell my patient that that's part of their testing. And they have the right of refusal with no punitive consequences. So you can say, you know, I don't think I need that. I gave blood last month, whatever it is, I don't need that test. And you can opt out, and there we can't say, well, if you're not going to get this test, we're not going to care for you. The difference is you don't sign an informed consent. You sign if you don't want the test. Now, this is a little bit of pressure, right? Because you're saying you don't want it, and I'm saying, okay, then you sign right here that you understand and you still don't want it. But the point of it is, if you fall through the cracks, you fall through the cracks on the side of getting tested, as opposed to an opt-in where you fall out and you don't get tested. So this bill was put into place. We celebrated. We were so happy. We never actually read every word. And it turned out that there were 11 words added in there, and I can't recall them off the top of my head, although at one point I thought they were etched into my brain. But that basically said, you don't have to do informed consent, but what you do have to do is educate. And then you have to have the woman sign a piece of paper that she's been educated and she would be in the position to give informed consent if that were necessary. So that's essentially informed consent. So at first, people thought, oh, we don't need consent. We didn't see any babies come through. And then people started checking the wording and saying, you do need that. Testing went down. It basically stopped again. So in the meantime, and this is my failure, 9 babies were found to be infected in 2.5 years, after none in the preceding few years. I say that's my failure because it wasn't until baby number 8 came through that I thought something is wrong. I should have known it at baby number 2 or 3, but we didn't realize it until we started seeing enough and said, what is going on? So what we did was a case review and noted that the screening wasn't being done, which led to the discovery of the 11 words. And so we returned to the legislature with a heavy heart, a little bit more tempered conviction, but still that position that this was the right thing to do. And in the 2011 session, a true opt-out bill was passed and is now in effect. The rules were written sometime late last year. So now it is effect that you get the test routinely with notification and you have right of refusal. And no consent, no informed consent, written documentation is required. One huge argument with this was, would this keep people from accessing prenatal care? And what we knew at the time was Alberta, Canada has had an opt-out policy for many years. And within 4 years of its institution, they had a less than 1% decline testing and no decrease in their prenatal care visits. In the United States, over time now, we've had enough time to do our own studies, and what we found is that opt-in testing does not increase testing rates, and opt-out strategies do increase testing rates. From our own personal experience, in that same time frame that we had 9 babies, now we've had 2. So we do feel that this is helping, and we haven't seen any significant birth defects related to exposure to these medications. Does that mean none exist? No. But at this point, we have not seen evidence that any significant teratogenicity occurs. This is where you're going to see a little bit of, I hope, my evolution. Because over this, I have realized that there are negative effects to testing. There's psychological stress about waiting for your test result. There is disclosure issues. We worry about confidentiality. Do people suffer discrimination? I'm here to tell you, yes, they do. 18 years of my life. It's been 30 years since we lost Ryan White when we were talking about it then, and to this day, there is discrimination that occurs. We cannot pretend that it doesn't. This discrimination frequently leads to disenfranchised families and isolation of those families. And it's not just the infected person. It is truly the family, however they define family, that suffers effects of this. There still is physical endangerment, and we do come up against domestic violence over testing issues. So there are negative effects. So then I was asked to think about the ethical effects of this, and not just for today, but over time we have been thinking about this. So I'm going to tell you, there are murky waters ahead, because this is where we get out of my typical wheelhouse, and this has been my journey, my evolution to, I think, more questions and confusion than answers. I'll be upfront about that. Very recently, the bishop of the Lafayette Diocese, though, wrote a piece, and in it he said, medical ethics isn't really about having all the right answers. It's about making sure all the right questions are being asked. So that's the tenet I went with as we proceed forward. So I have a lot of sort of overarching questions about the ethics surrounding this testing and HIV and AIDS in general. So one is AIDS exceptionalism valid? So AIDS exceptionalism is this theory that this isn't like every other medical disease. Now, to me, I will tell you, it is a medical disease, period. But this idea that somehow it's different, and that somehow all the social factors from it should enter into our discussion has been a very common approach for all these 30 years. Was it ever valid? Was it valid at the time when people were openly being discriminated against? Is it valid now? What I can tell you is I sometimes would wonder if when we said, okay, every pregnant woman is going to get screened for hepatitis and syphilis, if we talked about it this much, if there were so many barriers. And last I checked, those diseases are all sort of transmitted in the same way. So it's never been clear to me why this disease, this particular one, has increased that feeling of exceptionalism more than any other. Secondly, I wonder if opt-out testing could be looked at as a good thing, because I told you, risk assessment, very difficult. And so if I'm trying to do a risk assessment, in my mind, I am discriminating between folks' level of risk. So I may say, based on race, ethnicity, color, socioeconomic status, where you live, you're at high risk. I'm not sure that that's the best thing for us to be doing. But if we just test everybody, does that take that out of the conversation? And by testing everybody, by it becoming routine, does this help us eventually get to the state of normalizing HIV and getting rid of that exceptionalism? I hope so. I'm not really too optimistic that it'll happen in my career time, but I certainly hope over time. Is this libertarian paternalism? This is one of my favorite phrases, so I had to work it in there. But basically that means that society constructs a plan or strategies that push people non-intrusively towards the best or most rational decisions. Okay, is that really a bad thing? And it certainly doesn't apply just here, and I'm going to give you 2 examples, right? You all got your flu shot this year. Okay, I know, because I talked flu forever. So we have said this is the best thing for our staff, our patients. This is for patient safety. And so we made a strategy that pushed people towards that decision. We also have it right in our Partnerships for a Healthier America that we're all seeing in our cafeterias now, right? So this happens over and over. So at what point is it a bad thing? And what point is it a good thing? Then you get into rights. Now, I thought a lot about this over the last couple of weeks. You know, my rights, my rights. I've said it a million times. Do I really even know what that means? And when you violate someone's rights, is that a slippery slope that's going to lead to other violations? Or could it be a really good thing that instills other rights in other people? I think that's very hard. And then finally, the last question is, so we increase testing, good for us. If we increase testing, but people can't or won't access the prevention efforts, have we really done anything? Now, I'm an epidemiologist, right? I'm an infectious disease doctor. So yeah, from that intellectual standpoint, I like to know the statistics, but if we haven't done anything with them, what does it matter? And so then do we mandate that people access those services? And so where does that end? So I looked up a right. I never really found a great definition, but I did find out what it means to have a right. To have a right means you have to be empowered to demand the enforcement of the right or to waive the right. And I work with children. So that becomes sketchy right there. So then I started reading more, and certainly we can discuss choice rights in the mothers who can make their decisions, but we have to talk about interest rights in the fetus or young child who has an agent acting on their behalf. Then you get into preferences. There are actual preferences of the mother that she can state. Well, are there hypothetical preferences of the fetus? And if they are, what are they? And the assumption that we as a society have made is that they want to be born healthy. That makes sense, but it's still hypothetical. But that's what we think. If a child could speak for themselves and empower their rights and demand their rights, that's what they would want. But you have to have an agent for that. And so then there's a whole debate about who should that be. And we'll talk about that a little bit. What if these conflict? What if what mom wants isn't what we think is in the best interest of the fetus? Or if what mom wants isn't mainstream society? You think, well, would there really be conflict? I will tell you the most common conflict that comes up is our mothers who read about these medications. You know, we have made such efforts with people to, be careful what they put in their body during gestation. And now we're telling them you're going to put 3 drugs in there that have all kinds of side effects. There are women who will choose not to do that, not only for their own sake, but they may believe that it's harmful to their baby. While society may still think you're not preventing that baby. It doesn't mean she's necessarily wrong, but that certainly is conflict. And then the idea of, does all of this discussion change in a voluntary pregnancy? If you decide to get pregnant, are you automatically forced to assume certain responsibilities because of that choice? So when I try to put this into an ethical context and put it in the discussion of some of the basic principles of ethics, I think there are really 2 that stand out. And one is respect for persons, and the clearest point of this being the mother, the pregnant woman's autonomy. And By saying we want to protect her autonomy, we're saying we want her to allow her choices, that she makes them for a purpose, that they are about her, and that she does it free of coercion. That's a hard statement. Now, a long time ago, when I first started this, I actually made the statement on multiple occasions that I could go into a pregnant woman's room, spend 10 minutes with her, and I would come out with a signed consent. And I thought that was a really great thing. Looking back, did she feel coerced? Because I was really telling her what I thought with zeal. And if I did coerce her, it certainly wasn't overtly and it wasn't intentional, but it still could have been coercion. And I think a lot of times in our zeal to protect the vulnerable, we may be exerting coercion and not knowing that we're doing it. I'll share an example with you. I have 3 children. When my first child was born, I knew I didn't want to breastfeed. Okay, so when I asked for formula at the hospital where I delivered, they were aghast. I mean, they were just so upset, and they would say things to me like, "What do you do for a living?" And I would say, "I'm a pediatrician." And they would say, "And you don't want to breastfeed?" And then that was way before the days of HIPAA, because I'm pretty old, and my oldest child is pretty old. But one of my friends, another pediatrician, had delivered the day before, and they sent her in my room to like talk me into breastfeeding. I felt horrible, like horrible enough that for a very short period I thought, okay, I have to do this. I have to do this. Nobody meant to do that, and they thought that they were doing the best thing for the baby, but that was still coercion. The way we have protected our autonomy historically through medicine has been through the informed consent. So the risks to the informed consent from the opt-out strategy are something that is heavily debated. So CDC and the World Health Organization and UNAIDS have streamlined the requirements and documentation for testing, as we discussed. Well, there are a lot of questions I have about informed consent, even outside of this. But what have I said over and over? Routine testing with notification and right of refusal. Well, can people really distinguish what is routine versus mandatory? There are some semantics in that. Now, to me, it's very clear, but that's because for 18 years, this has been my life. But in a 5-minute conversation, can somebody really differentiate those two things? I kind of have these visions that some of these conversations may go, okay, today we're going to do your labs, and you're going to get all these labs, blah, 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 and HIV will be in there, and so you've been notified, and you can refuse if you want. So do we de-emphasize that ability to refuse? Do we really make it clear? Because in our heart, I think we don't want them to refuse. So I'm not in those conversations. But you have to wonder, and even if we're not doing that, perception is reality, right? So if the patient perceives it that way, it could have an effect. There's a lot of talk about, do we need anything beyond general consent for care? We don't consent for any other lab tests, right? Once you've signed into the hospital, whatever you need, you get. And the only things that we consent you for are procedures. So why is this different? I don't know. If you come in for belly pain and you leave with AIDS, does that make it different? Is it different than you come in with belly pain and you leave with a diagnosis of cancer? In my opinion, it probably shouldn't. But then we're back to AIDS exceptionalism. And I really think we're a long way away from acceptance by society that the consent for general care includes HIV. And then there's always the question of people, are people really capable of giving informed consent on the spot? When they haven't had time to read about things, when they haven't had time to think and discern, can they really give it in a short, compressed time window? And what about our adolescent patients, right? 6 months ago, your mom was consenting for all your care, and now all of a sudden, because you've given birth, you're consenting for everything, including for this child. Did you developmentally whiz through that part of your life? Because that seems unlikely. It's important in this case because 1 million babies are born to teenagers in this country every year. So how do we approach the adolescent, and is that a different conversation? And then finally, the big concern, does everybody even know they're being tested? So there is a study in the United Kingdom, and this is all in the references. If you want it, I'll give it to you. But basically, they had 34 women who had an appointment, and they polled them, and a great majority didn't know that they would be tested before they went to their appointment, which I don't think is typically surprising, especially maybe for first-time mothers. 26 of 34 accepted the testing. 3, however, indicated that they accepted, but they had no idea what they were accepting to, and they never knew they had an HIV test until somebody told them it was negative. And then 6 declined. All 6 of those that had declined were aware of testing and had read about it prior to coming in. This one's interesting to me. When we're all worried about autonomy, 9 of those women deferred the decision to test to another person, a spouse, a significant other, or a mother, whoever, which I found very interesting. And then 3 of them said they felt overtly pressured to take the test. This is the part that concerns me the most. When they went back and they talked to them, only 9 of them could articulate why we even do the test. Almost all of them thought if they had a positive test, their baby was definitely going to be infected. And none of them had any idea how they were going to get their test results or how their confidentiality was going to be protected. This was an opt-in program that required informed consent. So while we say those words and we feel really good that we're protecting somebody's autonomy, there are studies that show it doesn't work quite as well as we had hoped. And then Michigan did another study after they went to an opt-in consent policy, and they found out that 16% of their population had no idea they had ever been tested. Now, I don't find that so much here. Most of the women that I encounter know they've been tested. What I do find, though, is I'll say, "And what was your result?" And sometimes they'll say, "Well, it must have been okay. I never heard that it wasn't." And so I think, I haven't done a scientific study, but I have encountered a lot of pregnant women, and I will say that that's our most common finding. The other ethical principle that I think deserves discussion here is the one of justice and beneficence. And I think, societal justice comes in here. So does protection of public health and prevention of transmission of an incurable, sometimes fatal disease to third parties who cannot protect themselves outweigh a woman's rights to autonomy? How do those things balance out? Now, it is very easy, I think, for society to jump on this side and say this side outweighs it because here's this poor little vulnerable baby. But I'm not sure how well we think through the autonomy of the women who are carrying them. And this is a line of Lucia's that I love to use. Does this marginalize the woman to the role of incubator? If she is not in the position to make the decisions and some other agent or force is making them, is she solely the vessel at that point? And I think we have to be sensitive to that. I kind of felt like the vessel anyway, regardless, and I think that's a pretty common thing for women. We need to be very careful how we handle that. And then who is the agent for the vulnerable, right? I think for most of us, and I've spent my life caring for children, the mother. In the case of a pregnancy or an infant, to the great majority of the time, the agent for protection is the mother. But who's the agent in this setting? And what qualifications does that person have to be able to speak on behalf of not only one particular fetus, but a nation full of fetuses? It's hard to know who that is. Is that the healthcare system? Is that the legal system? And how much prescriptive powers do we give to that person who's acting as the agent? What do they get to say? Do they get to say only about testing? Or are there other things that they can say? Well, the fetus would want to live in a good house, and they would want to live here, and they would want a good car seat, whatever it is, right? How much power do we have in those prescriptive instances? And what about the cost to society? So there are huge costs to society, certainly financial costs to society. I can tell you the average medication bill runs about $3,500 to $4,000 a month. That isn't going to go away. People aren't going to suddenly get off medications until there's a cure. These medications have tremendous side effects. So we see everybody 3 or 4 times a year if they're doing great. And we do a battery of tests that are not inexpensive, that are, I don't even know how much they are, to check organ functions, viral load, how are we doing? That's if they never get sick. So that cost is huge. The cost of children who are left orphaned by deaths of their mother adds a whole nother level of cost. So these children require a tremendous amount of care. So does that give society some right to weigh in on how prevention efforts should be handled? And then finally, you have to know when you are testing that you have some minimum service package that you can offer someone who is HIV positive. That has to be available to them. Otherwise, it's very cruel, right, to diagnose and not offer treatment. Then there's the whole thing about what happens after you're born. So after the baby is born, the mother doesn't have to take medication if she doesn't want to. That's completely her decision. What she is required to do by law is protect any partners, either sexual partners or needle-sharing partners that she might have, but whether or not she takes medication or does follow-up is completely up to her. So we've forced her into medication in her pregnancy potentially, but what about after that? How do we keep her engaged for her own health and her well-being? And as a pediatrician, I'm selfish about that because I need that mother there. I need her well. I need her taking care of her children. And then finally, back to the slippery slope. Remember I said, when does a third party who's vulnerable, when do their rights outweigh the mother's autonomy? What about her contacts? Because it's voluntary partner notification. And so are those people vulnerable because they don't have all the information? And so then suddenly there is a different population involved in this conversation. And maybe it does become a slippery slope. So those are all my questions that I could come up with. There will be more and more and more, I'm sure, as time goes on. But I thought I would share with you some cases just to show you that this isn't a theoretical discussion, and this isn't just on paper. These are actual cases that we have encountered at the Ryan White Center for Infectious Disease at Riley. So the first one is someone that I wish that I knew better. She was diagnosed HIV positive on one of her first visits to her OB and was extraordinarily distraught, lost her significant other over it, basically was diagnosed with PTSD, and it was very hard for her in light of that to maintain her medication regimen and her visits. So she came sometimes, but not all the time. She did come in and deliver. The first tests were done on the baby, and then she disappeared. And so in this instance, this family had made an appointment in our office, and when they didn't show and we couldn't track them down, we did try to track them down through ISDH. We were able to find her. They were able to get her in one time for follow-up. We have not seen her since. So there are questions about how far do we track people, and where do they disappear to, and is she getting care, and is this baby infected, and we have no idea. The second case is someone who was offered testing at the first visit and says, I have no risk factors, I don't need to do this, I don't have this disease. She went through the rest of prenatal care. It was never brought up again. She presents in labor, and due to lack of documentation, appropriately so, was given a rapid test at delivery. The rapid test was positive. I got called because I have a woman now with a rapid test positive. What do they do with the baby? We treat the baby while we're waiting for the confirmatory test. Her confirmatory test, unfortunately, came back positive. She later said that she really did not know what the testing and treatment could do for her or her baby, and she pursued litigation against the OB. The OB was eventually exonerated from any wrongdoing because had the conversation and had documented it. But at least this woman's perception was that she didn't get how important this was. And so is it a liability issue if people decline testing? In the third case, the mother agreed to prenatal testing and screens positive for HIV. She then read up. She's a very intelligent woman. She read up on the drugs and decided she did not want to do prophylaxis. When the baby was born, she refused prophylaxis and was breastfeeding on the unit. She was born in one of our academic health center hospitals, and I was called about it. There is transmission with breastfeeding. There's actually significant transmission with breastfeeding. We estimate somewhere between 14 and 40% transmission risk. And so after talking with her and being unable to convince her otherwise, because people in Africa who have a lot of HIV are still encouraged to breastfeed, and she wasn't going to give up her right to breastfeed, we actually put the baby on a CHINS, which, in case you don't know, just stands for Child in Need of Services, which means the hospital takes custody of those children. And the baby was put in foster care. Not an ideal situation, but the baby was getting their meds. They were getting formula. And mom came for visits, and because reunification is always our goal, the baby was eventually returned to mom with assurances that she would give the meds and not breastfeed. And then she came into clinic to see me, of all places, and my nurse found her breastfeeding in the room. So at that point, what do you do? The exposure has already occurred. She loves this baby. I have no doubt that she is invested and she loves this baby, and she thinks breastfeeding is the best thing to do for this baby. Data did not convince her, I will tell you. And so this baby remains with its mother, and I can tell you that this baby, luckily, was not affected. The fourth case is a case that Lucia and I dealt with together. This is a young, unmarried female who came in. She had delivered a baby about a month prior. She came in full cardiogenic shock for unknown reasons, was not communicative. There was no record that she or her baby had been tested at any step along the way during prenatal care or at delivery. Her workup included an HIV test, and she did indeed have HIV. Whether it was the cause of her cardiogenic shock, we'll never know. But she had it. And so her medical team, in one of those moments where I'm just so proud of our residents, realized that they had this new HIV patient that they had diagnosed who had just recently had a baby, and that this baby needed attention, needed testing, and needed to get into care. And yet the mother was unconscious. The father wasn't involved. One maternal aunt was making the medical decisions for mom, and one maternal aunt was taking care of the baby, but there was no paperwork. And so to tell the maternal aunt in charge of the baby that this baby had been exposed probably from mom and needed to be testing, how did that fit into confidentiality and privacy? And so they called an ethics consult. And we struggled, and it's a very long story, but in the end, we did disclose to the maternal aunt, and the baby did get tested. The saddest part of this is that this mother died, and it is not clear to me if her HIV status had been known, what contribution it made to her demise. And if we had screened her during pregnancy, could we have helped her? And we'll never know the answer to that. The fifth case is sadly somebody I know very well. This mom is HIV positive, and prior to knowing me, she had delivered 3 children in the state of Indiana, all of whom were removed from her care for other issues, but 2 of them who happen to be HIV positive and are my patients with their adoptive family. She had been non-compliant with her treatment and the treatment of the previous infants as well, and so when she got pregnant the 4th time, she didn't want to lose this child, and she thought that it would definitely be taken away because she's HIV positive. And so she fled the state, went to a different state where they don't have an opt-out testing policy, actually. I don't think that's why she picked it, but it just so happens that's the way it worked out. And she did not get screened. She delivered the baby. She moved back to Indiana. At 4 months of age, her baby came in with pneumocystis carinii pneumonia, which at one point was the most common presentation of babies that were infected. It's one of the criteria for full-blown AIDS, and a long time ago that meant that your average duration of life was going to be about 11 months. Now, we do much better with it nowadays, but it's still a significant hit to a baby's health. So we told her, and we do that very carefully, because when you tell a mother of a newborn that the newborn's infected, you also have to say, and so that means you're infected as well. And she cried, and she was very dramatic, and it was heart-wrenching. And then I was off for the weekend, and one of my partners came through and rounded, and he said, "What is she doing here?" And he had cared for her other children and knew that she was HIV positive. So it was one of those moments when I thought, I'm pretty savvy at this. I've done a lot of it. It could have knocked me over. And so then this became, a debate. And eventually, for a lot of reasons, this child was put into permanent guardianship with a relative and continues to live there now. He's now 14 years old, and he's doing great. But 6 months after he was put into permanent guardianship, the mother again became pregnant. And so the debate was, what do you do? Do you put these people on house arrest? Do you force medicine down her throat? How do you keep her from leaving the state? You really can't. And so she continues to live her life. I will tell you this presents an ethical dilemma for me in other ways, because I have a few families where I have half-brothers and sisters who are adopted to different families that don't know about each other, but I actually happen to know that they're related. So I always have these nightmares. If one of them needed a transplant or something, what would I do? Because I would know where their sibling was. So I'm hoping that ethical debate doesn't come up. And in the last case, this is a mother who was tested in her first trimester, and she's negative. About a month after her delivery, she presents for illness. She did present with intractable abdominal pain, and she was subsequently found to have HIV infection, which got her baby referred to me, and unfortunately her baby is also infected. And when questioned about it, because we had a long discussion, what she told us is that she knew she was having ongoing exposures. She was having sexual exposures to her partner who has known IV drug abuse. And so she knew she was having ongoing exposures, but she was embarrassed to bring it up. And since no one ever asked her again after the first test, it didn't happen. And she really thought if she had one test that was negative, she would probably be okay. And she also considered litigation for negligent counseling, but did not follow through with it. And both she and her baby are in care and doing very well. So these are the things that we see. So like I said, this isn't just a theoretical discussion. These are real, happen all the time. I probably could give you 100 more stories, but we don't have enough time. So what did we do in Indiana? When we went through the last legislative effort, an amazing thing happened. So people who considered themselves advocates for HIV have done a tremendous amount of work over time, right? Like early on, they were the force that, literally chained themselves to the gates of the FDA, screaming for medications. They had ACT UP New York, ACT UP LA. They marched, they sat in, they did everything they could to bring about some sort of interest and effort on behalf of HIV/AIDS. But they always saw themselves, and as did we, in conflict with the medical side. Both sides were trying to help in the fight against HIV/AIDS, but had such very different ways of doing it that it took a very long time for us to all figure out we were on the same side. As a matter of fact, when the first guidelines were signed, advocates rushed into the place where the group was signing them and threw cow's blood on them. There are great pictures of them all sitting there in T-shirts that they purchased from Walmart down the street because they were covered in blood, making a statement that they were fearful of forced testing even back then. But in Indiana, we're very fortunate because IU Health, Legislative Affairs, and the Indiana State Department of Health were able to bring us all to one table and have great discussion and great work. So when we went to the legislature the last time, we were all on the same side in testimony about this issue. And then we partnered not only with those entities, but also the Midwest AIDS Training and Education Center, the Indiana Perinatal Network, the Centers of Excellence for Obstetric Care, Indiana ACOG, Indiana AAP, to sort of get a push, an effort, a momentum that was strong enough to help us get this through. Then we developed One Test, Two Lives, and now we're very careful. Now I read every word. Don't leave 11 out ever again, right? Every word that comes through, we sit in on the rules, hearings for the ISDH to make sure that the spirit of the law is followed in what it actually says. And I will never again wait for 8 babies to come through my door before I start looking at where they're coming from and what is happening with them. One Test, Two Lives is a campaign that kicked off here on World AIDS Day about 3 years ago. It's a bunch of materials for both providers and consumers. So there are algorithms for testing and delivery strategies and medications and all kinds of information. There are talking points of how to talk to people about this. There are frequently asked questions, and then there's a whole consumer portal. One of the best things we've added is that the passport. So women who are pregnant and HIV positive can actually have their own passport, and they can take it with them wherever they go, and their information, including their labs, etc., are right there for them to share no matter where they access the healthcare system in Indiana. We've had 2 mass mailings to OBs and pediatricians. There were over 5,000 packets of this sent out. So the hard copies were sent out and now can be downloaded from the web. We also sent a letter to administrations of hospitals that deliver babies everywhere that said, okay, You're going to be delivering hospital. Here are your responsibilities. These are the testing capabilities you have to have. These are the treatment abilities you have to have. You know, there are a lot of hospitals that have a lot, but do they have liquid AZT? Because it's really hard to get a newborn to swallow a pill, right? So you have to be prepared if we're going to do this. And then there's a website, and I'll show you a screenshot. This is what the website looks like, and you can get on there and get all kinds of information, including the up-to-date Indiana law, all the forms that you need for reporting purposes, all the resources that there are for care coordination and social programs, because I can tell you, we cannot treat the HIV positive without social, the AIDS Service Organization and the care coordination program. It's not successful. I thought I would just end with a couple statements about future and global considerations. Here at IU Health, I think we have a very good feel of the world now, and certainly with college student, I can tell you it's not about Indiana or even the United States anymore. It is about the world. The world has so much more HIV and AIDS than just the United States alone. And you can see from these numbers that it's significant. 90% of it is centered in sub-Saharan Africa. A lot of it at Kenya, where we have the MOI project with IU Health. And over 13 million children have been orphaned, and 1 million are dead, and that's just who we know, because it's very hard to track in that area of the world. But the interesting thing is AIDS is the #1 cause of death in children under 5 years of age globally. So it is a significant problem. And so one of the things that's coming about now is there a time to discuss mandatory testing? If 35 or 45% of your population is thought to be HIV positive, which are the estimates at the very least, when is it time? When do we change the semantics and we say mandatory? Entire generations are being lost in Africa, so is it time? And so there's basically two rationales for thinking about it. One is proportionate reason, which I think sounds more like a military operation than medical operation, but according to a sound prudential estimate, the good to be obtained is of sufficient value to compensate for the evil that must be tolerated. And secondly, there are the Syracuse principles that are legal standards for the protection of human rights. Do you have a legitimate objective? And is the restriction on the freedom to achieve that necessary? And have you tried everything else and not been successful? And so I think this will be the ethical debate for many years to come. But it may be time now that we're in a new situation that we have to rethink the way we've always looked at it. So that's it. If you have any questions, I can stay, or you can call me or email me at any time. But thanks for having me.
So